I am Dr. Manish Dhawan and I am working as a senior consultant orthopedics at Sir Gangaram Hospital, New Delhi. I also work in the same institute as professor of orthopedics at Gangaram Institute of Postgraduate Medical Education and Research, and I am also the teaching coordinator at Gangaram Hospital. My special interests include limb reconstruction for complex trauma, malunions, non-unions, limb lengthening for single limb, shortening and short stature, including achondroplasia. Adult limb deformity correction, I frequently use spatial correction like hexapod, the German fixator, SUV, the Russian fixator, Taylor spatial frame, the American origin, and DefFix, our own Indian fixator. And pediatric limb deformity correction also interests me, including congenital anomalies, clubfoot, hemimelias, genu valgum, varus, and congenital zoodarthrosis tibia. I have 25 years of experience in applying Ilizarov, LRS, and doing spatial correction. And I've done my training in Ilizarov surgery at various places. In India, I've done in Mumbai, Miraj, Vellore, and done my advanced deformity correction fellowship at Vancouver, Canada, Kurgan, Russia. My learning also included attending the Baltimore limb deformity courses couple of times. I hope my lectures will be useful to you. I'll be talking about management principles of proximal tibia, periarticular, and intra-articular fractures using circular external fixator. So before starting this lecture, I have done extensive study in the following books and literature. So that is the Transosseous Osteosynthesis by J. Ravel Abramovich Ilizarov, Operative Principles of Ilizarov, Textbook of Asami Group, Treatment of Fracture, Non-Unions and Bone Loss of Tibia with Ilizarov Method by Katani, Advances in Ilizarov Apparatus Assembly by Katani, Basic Techniques for Extremity Reconstruction, Mehmet and Kakmak, Advances Techniques of Extremity Reconstruction, Mehmet and Kakmak, Limb Lengthening and Reconstruction Surgery, 2 volumes, Svetlana Rosberg, M.A. Katani Atlas for Insertion of Transosseous Wires and Half Pins in Ilizarov Methodology. So these are acknowledgements which I have to give before starting the lectures. Now, Ilizarov method is a very useful modality in severe comminuted proximal tibial fracture, especially with skin problem. It has become a treatment of choice in selected cases of open fractures or fracture with severe soft tissue damage like blister formation, skin degloving, where internal fixation should be avoided. So this fracture is basically occurs in a very high velocity car or motorbike accident. So it is very common in younger age group. The surgery can be performed in acute stage of blister formation or severe swelling, as wires and pin help in decompressing the compartment. Now this is the main benefit of Ilizarov. Now if you have to do the plating of this fracture, so you have to wait for 3 to 4 weeks before the skin condition settles down, and then you can do the plating, but it is not in the case of Ilizarov. It can be done acutely. Now this is also a choice of treatment in infected non-unions. Now there are two types of mechanism injury. One is the high velocity trauma and second is the low velocity trauma. Now high velocity trauma causes excessively comminuted proximal tibial fractures, especially by direct impact on the knee in motorbike and car accident. Other mechanisms are varus and valgus deformation, axial compression, flexion and extension impacts. May involve the compartment syndrome. It can also involve the tibial and peroneal nerve and the popliteal artery injury. So this high velocity trauma leads to very high degree of disruption of articular surface and soft tissue affections and blister formation. So the Ilizarov modality is indicated in these type of severe soft tissue damage and many fracture fragments of the proximal tibia. Now low velocity trauma gives low impact injury and there are less soft tissue problems, and usually this type of fracture, this type of trauma causes fracture in the osteoporotic bone, and internal fixation is the right modality in their treatment because there are less skin and soft tissue problems. Now, Shatgar classification has been found very useful classification in management of these fractures because we know the idea of the fragments and we can plan our surgery. So it is 6 types. So type 1 Shatgar is a lateral split without depression. So it's just a split you can see and there is no depression. Type 2 is split with depression. So there is a depression plus there is a split also. Now type 3 is pure lateral depression. So you can see there is just a depression and otherwise condyle is okay. Now type 4 is a pure medial fracture of the condyle. type 5 is bicondylar. There are two fractures, medial and lateral condyle. And type 6 is if it in these two condyles they involve the diaphysis, then it is type 6. So Ilizarov is a very useful modality in Shedgar type 5 and 6 fractures. For other, from type 1 to type 4 you can use plating easily, but for type 5 and 6 it is one of the treatment of the choice. Now we will learn from the case. This is a first case. This is a 40-year-old male. He had a motorbike accident. He was a bike rider, and it was a very high energy trauma. He was hit by a truck, and there was a lot of extensive soft tissue damage and blister formation. There was no neurovascular deficit. So after the blisters were punctured, you can see the raw area of skin. The skin is very bad. So plating is difficult at this stage. So if you have to do the plating, then you have to wait for 3 to 4 weeks. So how do we plan it? So what we do that we do the investigation, and that is the imaging. So X-rays are the most useful. AP lateral view, sometimes oblique view is also very useful. We do the CT scan with 3D reconstruction. That is a very useful modality because you can find out where are the fragment placed and you can plan your fixation. Now MRI for ligamentous involvement MRI is not usually needed, and this is basically if you suspect that there is a severe ligamentous involvement, then you can do it, but usually it is not done in the acute cases. Maybe once the fracture is healed and then there is instability, you can get an MRI done. Angiography is done in cases of vascular injury. CT angiography can be done easily. Now this is the X-ray, this is the AP and lateral view. So now we have to see where are the fracture fragments and we have to plan our fixation. So what we do that we draw the fragments. So this is the lateral condyle fracture. This is the fragment which is in the yellow. This is in the AP view, and this is the medial condylar fragment, and the third fragment is a diaphyseal fragment which is in the blue color. So we can draw this in the lateral view also. You can see this is one of the fragments, this is the second fragment, and this is the diaphyseal fragment. So there are basically three fragments, and there is a depression also. If you can see, there is a depression at the lateral tibial plateau, so that is marked in the red. So this is basically the depression. So this is Shedgar type 6 fracture. So right choice for treatment in this case is an Ilizarov fixation. So CT scan will show multiple fragments. If you can see, there are many fragments and you can plan it. This is an axial view. See how many fragments are there. So, and 3-dimensionally also you can see from the back also. Now you have to plan that where you should place wires and the screws. Now what are the recent recommendations for surgery? So in young adults, intra-articular depression greater than or equal to 2 mm, metaphyseal or diphyseal translation greater than 1 cm, angular deformity of greater than 10 degree in coronal, varus valgus or sagittal plane, and in elderly greater than 5 mm intra-articular depression is considered for the surgery. So our tolerance for surgery is less in young adults because they have an active life, so we have to perfectly reduce them and then fix it. So what are the steps in Ilizarov fixation? So first you give traction and reduction of displaced fragments and hold them with guide wires. You have to elevate the intra-articular plateau fragment with a joystick. This is basically a 3 mm K wire. Cannulated screw fixation is done later on, and application of Ilizarov frame with olive wires in proximal ring. So I will show you animation how these steps are done, and then I will show you how we do the actual surgery. So these are the fragments which we have marked on our X-ray. So what is the first step? First step is traction. So once you give traction, what happens that all the fragments, the major fragments, due to ligamentotaxis, 80 to 90% reduction happens. But only thing is that the intra-articular depressed fragment is not elevated by the traction. So the next stage is that we have to elevate the intra-articular fragment. So what we do that we take a joystick that is 3 mm. You put it below the intra-articular fragment and raise it with the joystick. So once this is elevated, this plateau is elevated, That is the one of the most important step. Suppose you are not able to elevate with the joystick, then you can give a small incision and lift the fragment up. Once this is done, what we do that we hold the two major medial and lateral fragments with a guide wire. So this is the guide wire which is going. Now what we do that we put a cannulated drill bit over the guide wire and do the drilling. Once it is done, we see what is the exact length of the screw, measure it, and then put a cannulated screw over it. So once this is done, that you have made one chunk of medial lateral fragment into one. Now this is, once this is done, then the third fragment is the diphysial fragment. So what you do that you reduce it and then hold it with a guide wire, and then you put a cannulated drill bit over it, drill it, and then you put the cannulated screw. So this is the cannulated screw fixing. Once it is done, your surgery becomes very easy. You have to just apply the frame. But all along the traction has to be there. So what we do that we put olive wires, at least 2 to 3 olive wires. One should go from the medial side and lateral side to fix the fragment. So you can see there are this is the olive of the wire, this is the olive of the second wire. So they are fixing the fragment. So this is an additional fixation. Then you put a third wire, that can be olive or a normal wire. And also the benefit is that you have put the cannulated screw, so you can also use the whole of cannulated screw to put additional wires. Now you apply the proximal ring, fix it with the wire fixation bolts and tension it. Now for the second ring, you use the bayonet wire, put it in the middle, and then you apply the ring. Once this is done, so you fix both of them with 4 threaded rods. So this frame, half of the frame, proximal frame is done. Now you have to extend the frame down. So you have to put 2 to 3 wires down, and these are basically the trocar wires in the cancellous area. You apply the ring and then you connect it with the threaded rods. So now I will show you exactly how you do in the surgery. So first step is, most of the tibial plateau fractures have a severe hemarthrosis. So step 1 is always do an aspiration of the knee, and you can use a 16 gauge needle. This is a thick wide bore needle, because aspiration helps you, it reduces postoperative pain, and also it can be a cause of infection. So it is always the first step is that you aspirate the joint, and this will really help the patient in reducing the pain. Now step 2 is traction to reduce the fragment. So I have typically made these type of stands. You can see the middle, this one basically you can raise the fragment up and down, and these stands are very handy. So a assistant can give traction from this area, and once he is keeping it pulled, you see under the image intensifier, and put a couple of guide wires to fix the fragment. And also, if you don't have stands, then you can use you can make bolsters out of the drape and put it below the knee and the ankle, and you can perform this surgery. Now once this is done, then you have to use a joystick to elevate the tibial plateau, and you have to insert cannulated screw over the guide wires. So depressed and malaligned fragment to be raised or aligned with joystick 3 mm K wires. If not possible with joystick, use a small incision to open and raise, align the depressed malaligned fragment. Grafting is rarely necessary, but sometimes you might have to do grafting when there is a big depressed fragment, but I rarely use it. Use of guide wires for cannulated screws, and guide wires help in holding the fragment as well as in screw placement. So this is, you can see the picture that we have used fix the fragment and guide wires, and then we have put the cannulated screws. Now once this is done, then you have to apply the Ilizarov frame. So what you could do that you use 2 to 3 or sometimes even more olive wires to fix the fragments, and you can put an additional wire through the hole in the cannulated screw. So it is usually a 3-ring frame, and proximally ideally we should use a 5/8 ring, but in tibial plateau fracture, because there are multiple fragments, so you require to sometimes fix the posterior medial and a posterior lateral fragment. So sometimes it is very handy to use the full ring. So this is the very simple frame. So this is the post-operative X-ray. So and once you have done put the tibial frame, you have to check the knee instability. If knee is found to be unstable, so you can add a femoral ring, and this ring you can remove it after 4 weeks. Now, what is the post-operative protocol? You have to elevate the limb with analgesics and anti-inflammatory coverage is given. Partial weight bearing is started as soon as patient is free of pain, or third or fourth day you can start with walker or crutches. So ankle and knee mobilization, quadriceps, abductor strengthening, pelvic floor exercises on the third day is started. So you have to do daily pin site cleaning. Once the wound is healed, patient is allowed to take bath. Now for the pin site cleaning, the best solution is that you use boiled and cold water, because sometimes what happens, the betadine, the chlorhexidine, the hydrogen peroxide, the spirit which we use, it can be a skin irritant and cause problems. So if the femoral rings are used, you have to remove it after 4 weeks, and knee bending is encouraged after that. And frame removal is done around 4 months. It takes around 3.5 to 4 months for this fracture to unite, and you can remove it easily. Now, follow-up of the same patient at the time of frame removal. You can see a good union of the fracture. So at the time of removal of frame, you can see his knee movements, his knee bending, the upper tibial ring touches the thigh, under surface of the thigh. So once after removal of the frame, you can see his movements, the knee movements are full. You can see full knee movements. So that should be your purpose of the surgery, that if you could give a good joint movement to the patient and there is no stiffness, then your surgery is very successful. Now coming to case 2, this is a patient who is 67-year-old, was a pylon rider on a scooty, and he had a very high energy trauma, and there was extensive soft tissue damage with blister formation. There was no distal neurovascular deficit, and he was operated last year in 2022. Now you can see the amount of blister formation and skin damage, and after the blisters were ruptured, you can see the raw area of the skin. So there are multiple fragments. You can see there are many fragments. It is in AP and laterally you can see. So we have to plan now to fix them. Now the frame was applied, 2 cannulated screws were put in the proximal fragment, and it's a 3-ring frame, and you can see the raw area of the skin. Now the patient was standing with the frame, you can see his knee movements. The ring is abutting his posterior thigh in flexion. That is all is required. He should be able to touch the ring, the proximal ring, to his lower thigh. Now patient after removal of the frame, you can see he is standing, and you can see after the removal frame, you can see the position of cannulated screws. The cannulated screws are retained for, you can retain them or you can remove it after maybe 18 months or maybe after a year. So do not remove cannulated screws when you are removing the frame. You can see the patient is walking on a walker comfortably. We have just removed the frame. Now coming to case 3, this is a 54-year-old man, had a motorbike accident, high velocity injury, severe soft tissue damage and blister formation. It was a Shadgar type 6. So you can see the blister formation, and this is the fracture. There are 2 basically big chunks, and you can see this thing, it is extending to diaphysis, and similarly 2 cannulated screws were put, and after the removal of frame, you can see the knee movements of the patient. Coming to case 4, this is a 78-year-old male, fell down from 7 to 8 stairs, and he was operated for on the same day. Had simple Shadgar fracture with blister formation, but he had a blister formation, that's why internal fixation was not done. He had severe impact on knee with the twisting injury. So this is basically a simple looking fracture, and you can say it's a lateral condyle fracture, it's a Shadgar one. You can see the damage to the skin, and you can see the raw wound also. So primary Ilizarov fixation was done on the same day. Patient with the frame, and you can see so he is not using any walker or a stick. He is able to put weight and walk. Now coming to case 5, this is a 66-year-old male fell down from a scooty and had Shadgar 6 fracture with compartment syndrome with blister formation on the skin, and he was admitted on 31st January 2023 and operated after 2 days. So this is the situation. You can see the blister formation and see very bad type of fracture extending till the diaphysis. So this is a complex fracture pattern. So similarly we had put cannulated screws and put the 3-ring frame, and patient, you can see his walking video with frame, Ilizarov frame on. Now coming to case 6, this is a 32-year-old male with a high velocity motorbike accident, had Shadgar 6 fracture with impending compartment syndrome with blister formation on the skin. The fracture was extending down till lower third of tibia, and Ilizarov was the only feasible method of treatment in this case because we could not apply or plan for a very long plate. So you can see the situation, the proximal part, very bad fracture extending down, and it was stabilized by the Ilizarov frame, and you can see his knee movements after removal of the frame. Now we have done literature search, and a lot of articles are there on tibial Shadgar 5 and 6 tibial plateau fracture, where they have compared plate fixation, double plate fixation with Ilizarov fixator. So there is a similar article, treatment of fractures of tibial plateau Shadgar 6 with external fixator versus plate osteosynthesis by Federico Francisco et al. So in this paper, if you see group A, so the excellent to good results are almost around 94%, and with the plate fixation you can see the excellent to good results are around 93%. So Ilizarov gives the almost same the results of the plate fixation, but the benefit is that less invasive procedure. It's a minimal invasive procedure. Patient can walk over it. Now if you apply dual plate, you will not allow patient weight bearing, but with Ilizarov fixator, patient can walk from partial weight bearing from the very third day or when the pain reduces. Now there are other studies in the literature. One study, Tahir et al. Involving 137 patients with Shadgar 5 and 6 fractures, and he found no significant difference in terms of clinical, functional, radiological results in patients who underwent internal fixation, double plate and Ilizarov external fixator. Now Bowie et al. Compared minimally invasive plate osteosynthesis and circular external fixator in Shadgar 6, including 28 patients, and reported the similar results. Subramaniam et al. Reported no difference in terms of functional and radiological outcome in patient treated with circular external fixation, with or without minimal internal fixation for bicondylar tibial fracture. So Ilizarov method is a more cost effective and related to fewer complications than open reduction and internal fixation with dual plate, because there are so many problems. You can get skin problems after surgery, and also infection can be there in a bad skin if you do this. So there is a paper review has been done on management of tibial plateau fractures and by Mathiva, and he has described the criteria, what are the indications for tibial plateau fracture. So for Ilizarov fixation. So in open fractures, compartment syndrome, vascular injury, lateral tibia plateau fractures with articular step greater than 3 mm and condylar widening greater than 5 mm, coronal plane instability, displaced medial plateau fractures and bicondylar fracture. So prospective study was done in my hospital by me at Sir Gangaram Hospital, New Delhi, and the study included 30 cases of complex high energy tibial plateau fractures between January 2006 and June 2018. Patients were followed up for 24 months, average follow-up was 12 months. Inclusion criteria was patient of either sex over 18 years, Shadgar type 5 and 6, and some patients with fracture, same patients who had fracture in other limb was excluded. Youngest patient in the series was 30 years and oldest was 60 years. There were 24 males and 6 females, and there were 18 cases of left and 14 cases of right tibial plateau fractures. Femoral ring was used in 7 cases due to instability of the knee, and ring was removed at 4 weeks. 6 patients required open reduction with elevation of tibial plateau and bone grafting. The bone grafting actually is rarely required in a very badly depressed fracture. If you have to elevate it, but most of the time bone grafting is not required. A simple elevation with a joystick does the job. So results were graded according to Hankonen and Javerin criteria and include clinical, state, functional and radiological assessment. All fracture united at a mean 13.2 weeks. All patients achieved full extension. 16 patients were able to flex more than 130 degrees. 10 patients achieved flexion more than 110 but less than 130 degree. 4 patients had flexion loss less than 110 degrees. At follow-up of 24 knees were fully stable. 6 patients had slight instability and limp. Complications included: 1 patient had delayed union and required brace. 3 patients had impending compartment syndrome, required fasciotomy. Actually, these patients already had compartment syndrome and they were fixed with the Ilizarov and fasciotomy was done. 2 patients had DVT requiring low molecular weight heparin. So we had DVT with Ilizarov. So I think if patient is immobilized for a long time or is not walking, so it is better to give a DVT prophylaxis. But the benefit in Ilizarov is that you make the patient walk, so that you can control that. No case of severe infection seen, skin sloughing or osteomyelitis was seen. So we had around 45 excellent and 30 good, that is around 75% excellent to good results. So in conclusion, Ilizarov fixation is one of the indications for treatment of Shadgar type 5 and 6 bicondylar fractures with extensive soft tissue damage. Fracture with extensive soft tissue damage can be stabilized in the very first week without waiting for soft tissue to settle down with Ilizarov fixator. In these fractures, sometimes you may have to wait for 2 to 3 weeks before you plan for internal fixation with a plate. So that is the benefit of Ilizarov. Thank you very much, and I think this lecture will be useful to you, and we will be coming every time with new lectures, and I hope this will be useful, and have a good day. Thank you.